Hello and welcome to another episode of the Melbourne Athletic Development Podcast. We are very fortunate to have a returning guest for the first time ever, actually. Richard Newsham-West, Dr. Richard Newsham-West, I should say, has joined us for another talk, and we thought it was a good opportunity to talk to him because his role with the Latrobe Physio School has changed. And he's got some exciting developments, and we thought it would be good to talk about what that means, both for him and also for the education of our profession. So, Richard, do you want to tell us a little bit about what has changed in your professional position?
Yeah. So my new role. My new role is involved with a team at Latrobe now that we've, as part of the health initiative which Latrobe was running, is to build a brand new clinical training school or building, which is going to have a clinic in it.
That's cool. So, student clinic.
But it's going to be a little different from the traditional student-led clinic.
In what sense?
So we're going to call it a student-assisted clinic, which means that the
students are doing nothing.
The students, yeah, that's right.
They're sweeping and vacuuming. And
yeah, making me coffee.
Bring me my cushion.
So we're moving a little bit away from the traditional apprenticeship, see one, do one. So we're actually going to be working alongside each other.
Yeah.
And so that the students are part of the healthcare, not just sort of helping with the healthcare.
Yeah. What prompted this? Because I remember 2008, 2009, when we were finishing off our undergraduate degree. We were at Melbourne Uni, and I kept saying to them, why do you idiots not have a student clinic? Like, to me, it seems so pointless that most of us want to go into musculoskeletal health, right? And we're stuck doing orthopedic only in the hospitals, and then we get maybe 2 weeks at a clinic we actually would be interested in working, or the type of clinic we'd be interested in working in, and then we're left to our own devices to develop a lot of the other skills. And they never had a good answer for me, so it seems like you've arrived at a good one.
Well, the good thing about this too is, and you can share in these, you've gone through this process before.
Yes, I've been
a serial clinic setter-upper.
That's right. Don't need it out.
Well, you don't have to just hypothesise about what the benefits are. You know what the benefits are.
So to answer the question, I think there's a couple of things. The first thing is that what happens with clinics, particularly not the hospitals, so the private health clinics, is that they're only funded on treating someone. And so clinical education or training of a junior practitioner is expensive, because you've either got to decrease the quality of care or you take you away from the ability to give that care. So there's always this sort of fight between you as a practitioner and you as a clinical educator. So I think that a lot of people universities haven't traditionally gone into that space because it is quite expensive.
Yeah.
And then the other problem is that if you set up a clinic which is going to give a student a huge breadth of experiences, you don't quite get the quality of care, because you almost have to go to a community-based sort of low-level. You don't get, and people don't want to work for you in that space. Or if you go to a specialist clinic, people get a lot of experience, but it's only in a very refined space. I think the other thing that has been not an issue, but one of the things that people have focused on is the apprenticeship model of education, or apprenticeship model, and we've always thought about the difference between education and learning. And learning teaching is learning a skill set, and we then fall into this competency-based framework. You can do one, tick one off, move on to the next one, instead of actually being that higher level education, which is where you're starting to draw on what I call, they're still clinical, but it's the higher level thinking, and being able to reflect on yourself and go, okay, I've sat down here with a dietitian, for example. What a part of their clinical reasoning can I take into my clinical practice? And so there's that, what I call high level and career based. And I think that's one of the things that we're going to be looking at in this training, is that can we train, as you just said, can we train and get someone ready to to be ready for private practice or working in the community musculoskeletal sports or whatever we're going to be in that area of community care. But we're also, well, I'm quite passionate about this, is actually trying to make sure that we don't lose that person after 3 or 4 years because they're bored. You know, because we've trained them to be able to mobilise a joint and rehabilitate a hamstring, and then they go, well,
what's next?
Because
when you look at the statistics too of physios that leave the profession, it's pretty damn high after 5 years, isn't it?
Yeah, look, and that stats comes up every time, and I've always wondered that, because it'd be interesting to see if that aligns with other professions, because a lot of other people go, after 4 or 5 years, I've paid off my got a bit of my student loan done, got a bit of cash in the bank, OE, or I'm off overseas, you know, and do they come back? They probably don't come back, but they're recorded as a loss to the profession. But I also think that the other thing that really is interesting is that physios are very bright people. And I think this is where I come back to the well, exception of us in this room. But there is that sort of career. Instead of training just to be a physio.
Do you know what my theory is on that? Is I actually think that we're stooged in this country because the people are too smart and they're actually heavily understimulated when they get into the profession. Because if you end up in an environment that is not challenging you, you actually lose a lot of motivation. And that comes, you know, people would know a lot of the motivational theories, but one of them that I find quite interesting is that whole, you know, competence thing. And I don't think that people actually understand that there needs to be that nice balance between challenge and skills for you to actually have a high level of motivation. And when that's not being met, it actually means that intelligent people try and move to something where they feel they're being challenged. And you always get this thing where people will do stupid things and they'll challenge themselves, not intellectually, they'll start trying to work like and see 25 patients a day. And then they justify it because they're getting paid reasonably well to do it. But that's not really why they probably got into it, because they thought that there would be some intellectual challenge to it.
Yeah, look, I think you're right. I think, and that's probably where I'm saying that it's the profession.
Yeah.
You know, we think about physio profession being only with a patient in front of you. In fact, it's actually a lot bigger and wider. And I think you're right. People, they get into this almost competency-based, I mean, I don't know if this is the right word, but a competency-based management approach. And you're absolutely right. You get bored. You know, if every joint you have a go-to methodology, you will get bored. I think the challenge for the profession is to look at people like myself who've been in the profession now for over 30 years. Why am I still in the profession?
Yeah.
Why am I still excited?
That's the interesting question. Like, what's unique about why you find this interesting and why you're still here?
Yeah, not worry about why people are leaving, but why are the people saying?
Well, you're probably going to get much more information.
Yeah.
Well, okay, let's ask you that question. Why are you still here?
Oh, that's a very... I mean, I love that question, because what it does is makes me reflect on why. And in reflection, I think it was meeting a physiotherapist once.
I'm just laughing and hear something going on in the background there.
I'm trying to ignore it.
Someone's banging something.
Yeah.
Someone's making chopsticks. And he showed me the power of being inquisitive. And
you can actually put it down to that one unique moment.
Yep.
That's pretty cool.
Yeah, one unique moment.
And you've reflected on this before?
Lots of times. Yeah.
Who was this guy?
So he was he was actually a professor of philosophy.
They're always philosophers.
Yes, but he was a physiotherapist that ended up leaving the profession and going back and doing another degree and did philosophy. And he just showed it was a conversation over a cup of coffee, and we were talking about the
meaning of life.
No. We were talking about
From a physio's perspective.
Existential crisis of being a physio in the modern world.
Yeah. No, we ended up talking about the history of coffee and how
the slave trade.
But yeah, the good side of coffee, but that's the bad side. The good side of coffee was that when the coffee revolution came along, prior to that everyone was drinking alcohol because the water was so bad.
Why wouldn't you?
Well, that's true.
Because that was actually the way to sterilise water, was making beer, wasn't it?
Yeah, and so they were going at lunchtime and having a beer. And when the coffee houses came around, then people were drinking coffee. And that's where all these sorts of stimulated conversations, and we ended up talking about what the hunch was.
You'd have some pretty good conversations
when you're drunk.
But
the thing is, you can't remember them. That's the problem.
You need a scribe there to write down everything.
That's right, I know. And what did the guy off Cheers say? That he reckons alcohol actually makes you smarter but he said it was like...
well, you think you're smarter at least.
Well, his theory was that it's like the lions and the African plains, and they chase always the slower animal and eat them, you see, and alcohol does that to the slower brain cells, so you actually become brain.
We actually just spoke about this with our previous guests off air, but we were talking about, I won't bring it up too much, but the flow state and the fact that it's like a down regulation in some ways of some of that sort of frontal cortex behaviour, and alcohol does that, so that potentially opens up opportunity for exploration. I know there was a guest on one big podcast that spoke about, for all the bad things that alcohol does, it does actually have some major benefits, not even just as a social lubricant, but actually for opening up creativity. And that's become a big area for accessing some of this sort of flow state stuff, is the use of microdosing hallucinogens and all sorts of stuff like that, because you're getting some downregulation of that frontal cortex, enough that you can start to use different parts of your brain in a different way and sort of get into that almost daydreaming state where you're less sort of rigid in concreting your thinking.
This is a recommendation for the student clinic, John.
Hallucinogens.
Magic mushrooms on the roof. But I think it's this guy's taught me how to question my hunches, and I think that's where I started.
What was his recommendation?
He just said you just question everything.
Yeah, a level of skepticism is extremely vital, I think, if you want to be, this will sound very critical, but an interesting person.
But I think, yeah, absolutely. And I think the other thing that he also talked about was how, as a profession, and I think this is every profession, we're guilty of, all we do is we tend to just read physio stuff. So we've become very physiocentric. And so what happens is you then look at the world through physiotherapy lenses, and I think that's another reason why we lose, because we get bored of looking at that so often.
And that can become even region specific too. Like we look at research within Australia, and we don't necessarily get exposed to it as frequently from other countries, even by geography too.
And we listen to podcasts, and we listen to read everything that's self-confirmation, not challenging.
And you're not listening to, someone speaking in Chinese or in Russian.
No.
I always wonder that too, of some of the research that's been published in the non-English speaking language.
Yeah.
I'm sure there's actually some very interesting stuff when you think about, like, I know we've talked, John, before, like with jumps and things like that, jump coaches, a lot of the stuff coming out of the Russian.
I'll tell you a good story. I don't know if you know who John Boas is.
The name's ringing a bell, the dark depths.
Anyway, he's one of Australia's best ever long and triple jump coaches. Yeah. Right? He's 80 odd now, and he's actually he's also a physicist, an experimental physicist who worked at Monash for a long time. He's still doing a little bit of research as a sort of semi-retired physicist. And early on, a guy came along named Ian Campbell, who ended up going on to win a medal at the 1980 Olympics. And at the time, John was coaching middle distance because he was a middle distance runner himself. And Ian came along and said, "Hey, I want to triple jump. Can you teach me how to triple jump?" And he thought, "I don't know anything about triple jump. I'm going to learn." And being the smart person...
How long ago was this? It was like 70s or something, was it?
Yeah, well, it must have been probably the early 70s.
Yeah.
Because Ian came along when he was about 15, I think. And obviously I said 1980 was when... He should have won the gold medal, but they screwed him, the Russian officials in Moscow. They said that he dragged his foot, which at the time was considered a foul, but he didn't. The video shows it. And so he didn't end up winning, but he should have. But John, being the smart guy that he is, thought, okay, well, where do I get triple jump knowledge? Well, most of it's in the Soviet thing. So he taught himself Russian, and then he started reading all of the books and translated them so that he actually had the knowledge to do it. And I think that, one, it speaks to the brilliance of John Bowles himself, but also what Jack just mentioned, that there's so much knowledge out there that we discount because we don't actually know how to access it, even just from a basic language point of view. And I'm sure there's so much research that's being done in the medical fields that we go, oh, there's no research being done on this. And then if you go and speak to someone, as you said, whether it's, you know, in an Asian language or, you know, Spanish or whatever it is, and they go, oh, no, actually, like, this has been done for the last 15 years. Like, we've got lots of research. And you go, oh, we don't know anything about this.
Mm. And I think the other thing we do is we dismiss it if it doesn't fit the traditional randomised controlled trials or, you know, statistical binary that we love here. Well, and we just dismiss it.
We saw that a bit with COVID, actually, because there was a bit of research coming out of Chinese labs, and there was so much distrust of China at the time. They were saying, like, don't listen to anything they're saying. And I don't think that that's necessarily fair, because I'm sure a lot of these Chinese scientists are doing, you know, everything as closely as they can to the book.
Yeah, and I think that it was the problem with the Soviet era when behind the curtain, you know, that we didn't know what was going on. No. So anything that did come out was rubbish. We didn't want to accept it as being rigour. Yes. So I think that's that's one of the things that I
Is this still around? What's his name?
No, he's not. He died about 10 years ago now.
Oh, that's sad. We should have got him on the podcast. Yeah. maybe we can do an AI generated podcast with him.
Yeah, that's right. But I think that made me start to think, and it was probably when I really started enjoying clinical education.
How old were you at the time?
So I would have been 30, early 30s.
This is a question for you, and I'm thinking on the fly here, but I feel like one of the big problems that we've got, and I'm not blaming younger generations, because I think that the time cycles and time horizons seem to be shrinking on careers, and I think there's much broader data than physio that shows that people change careers X amount of times, where in the past they didn't. But I think one of the things that actually has been nice, and I think you're alluding to this, is once you get to a certain number of years into the profession and you're a little bit older and probably, hopefully, a little bit more mature as a person, your ability to self-reflect changes a hell of a lot. And it probably starts to open up areas for professional and intellectual exploration that you didn't understand that maybe you even had. But most people, I don't know, even get to that point because they go through that sort of frustration period where maybe you don't feel like you're progressing, but that's actually that important struggle period of learning, you know, and there's a lot of this talk in the psychological realm of learning of, you know, post-traumatic growth sort of thing, not only for psychological experience, but actually from learning, you know, like you actually have to struggle your way to improve understanding of something. And I feel like there's a little bit of, and maybe I'm being judgmental, but there's a little bit of that where people are kind of not pushing through those 3, 4, 5 years where you're like, I'm not sure that I actually know what the hell I'm doing here. I'm not quite beyond that other side of the mountain yet, and I don't even understand if this is who I am or want to be, or do I want to get to that. And it's interesting you say you were around 30, because I feel like it took me to about late 20s, early 30s, but I was like, actually, I do want to do this, and I do really enjoy this, and these are the things I'm going to explore, and I'm going to be pretty steadfast on doing that, irrespective of, you know, the challenge that it presents.
I think part of that is that Dunning-Kruger effect too, where, because you want to feel confident in thinking that you know everything, basically. But then I feel the more you work within a health profession, it's probably one of the good things about physiotherapy, because you have a lot of autonomy to take different approaches, but you start to figure out a lot of things that you were taught or you thought are right don't necessarily work, at least all the time. But then it gets into that issue of you question everything, because it's like, well, is there a definitive answer to treat this particular injury? And the reality is there is a lot of variability or breadth for how you actually approach that particular injury based on individual characteristics. But then you go into, you go into that area of complexity. So it's actually being open to the fact that, well, I can't be definitive in giving you the exact answer or protocol, because from my experience, I know that's not always going to work. And I think part of that issue is, are people actually open to that uncertainty or willingness to approach something knowing, okay, I have to be flexible with how I approach this? And part of that is also that life learning experience too. Because I also wonder, do people actually become a bit complacent or disinterested or even potentially lazy with actually wanting to continue to pursue knowledge?
Yeah, I think there is an element of that, but I also wonder whether it's actually, I don't need to know that. I think because there's, I see a lot of, it's going to sound very conceited, but junior physios, and I can say that because I'm older, but...
How's that conceited?
Well, I just...
All you younger idiots.
Younger idiots. No, the younger, I call them the younger people, the Padawans, yeah. The younger, and I call them again career. So these are the even 10 years out of physio school. They always talk to me and say, well, I don't do that because there's no evidence for it. And I always turn around and go, well, that's bullshit, because the client has just shown you there is
some evidence to do it. Yeah.
And I like it to the I just had to give a provocative discussion once at one of the forum, and I went and looked at all the abstracts that were submitted over a period of time to the musculoskeletal group here in Australia, and then I plotted that along a timeline. And then I also, so the type of publication that was submitted for conference, and at the era of evidence-based medicine, there was a change. So early on, there were case studies and case series and a few randomised control trials and a lot of science by first principles, does wiggling a joint move a joint? We could do those sorts of things. And then in evidence-based medicine, the systematic reviews and the randomised control trials came
nuts, yeah.
And they went over the top, and these other things just about dribbled off. Then the interesting thing I threw on top of that graph was where the innovators, the people we thought were really good clinicians, the Robin McKenzies, the Brian Mulligans, for example, and they all occurred before that, Maitlands. After that?
Gone.
And I wonder if there's a bit of that.
Oh, definitely.
They, you hear about these guys once upon a time. They used to have at a conference where they would treat a patient on the stage, which that almost seems unheard of now. Well, not unheard. It is unheard of now, where it almost seems to be not validated or actually respected. Of like, let's actually just watch this individual do what they do. And they can obviously deconstruct what they did afterwards, but actually say, like, how do they actually go through this whole process of not just talking about theoretically, theoretically we're doing this and the research shows this. It's all essentially lip service in a way of like, well, let's actually see that applied in practice, and let's see how you as an expert clinician apply everything that you do know and have learnt.
And that was one of my joys that I've had, is teaching with Brian Mulligan, because Brian Mulligan was like that. He taught me probably one of the several skills, but the one thing that I remember him, and I've stuck with me now with my teaching, is he was able to turn his thought round and expose it quite happily to be shot down, but for the audience to dissect. So he was actually able to take his thought, and in a way it was going back to my hunch theory. He had a hunch with his patient. He then talked about his hunch verbally with the client, with the people in the audience, and then did it with the patient that was sitting in front of us.
Again, I think that highlights that inquisitiveness of him as a clinician as well. Do you think that that's something, not that we're going to screen for it, but do you think that that's something that is likely to be something that keeps people in the profession, is that they naturally have or develop some of that inquisitiveness, curiosity, that they want to kind of keep developing their understanding of things?
Yeah, and that's what I've been, over the 3 universities that I've worked at in the postgraduate era, that's the whole focus. I say to the students, you're never ever going to learn something new from me, but you're going to actually think about what you're doing.
Well, and this gets back to your current endeavour where you're setting up a student clinic, because I think that's something to consider, is how is the current model of teaching, say, physiotherapy without a student clinic, how does that actually look, and how does that differ to actually having a student clinic? Like, where do you think the actual value and benefit lies in opening up a clinic for students?
I think what it does is there's a couple of things, and I think that it could very easily just become four walls in a clinic, and I think that it could.
Do you want to on that? Do you want to describe that model's difference? You mentioned at the start, but you didn't go into any depth. Like, how are you looking at applying this so it's a bit different to, like as you said, four walls and a patient?
So the first thing is if we read the literature and what we're going to be looking at is empowering the clinician to be a clinical educator. So it's not just tacked onto your clinical role. You are timetable, workloaded, whatever you want to call it, to be a clinical educator. And we train you to be that. We give you the ability to be able to.
What level is this being pitched at, though? Is this postgraduate?
Undergrad and postgrad.
So even as an undergrad, you're being asked to educate other... Is that what you're suggesting? Yeah, you're being asked to actually have time where you're educating other people clinically.
Yeah.
Interesting.
And then...
How do you think they'll go with that?
Don't know.
Have you tried it before with previous...
I tried it at Griffith.
How did it go?
It went really well, yeah.
What was the sort of approach of the students when, particularly as an undergraduate, when you think, well, I don't know much, what am I going to teach?
So then what you're trying to do is not teach. So it's almost like opening up their ability to be an educator. So an educator means that you're not teaching a skill and then measuring that skill. So because they don't have that. So I could sit down and talk about tendons and biology and all that for hours. I'm teaching them that. Then I'm going to examine the knowledge retention. But if I'm going to educate them, it's that higher level thinking about philosophy or in PCLW, you're thinking about and questioning their thought processes so that a student can actually educate their peers. They might not know anything, but if they go into that situation saying, why did you say that? Trying to understand why, they actually, in that process, will educate themselves and educate the others. So it's an interesting thing, because what I did at Griffith was we did this because I've always felt this, that when you're with a client as a supervisor and a student in the room, is a three-way conversation.
Yeah.
And three of you are going to learn something. I'm going to learn something about this.
It's interesting you say that, because now that you say it, I recognise that often when we have students, the patient actually heavily appreciates the conversation that you have with the student, because they feel like they're learning a lot more about what's going on than what they normally would.
Absolutely.
It's very interesting you say that, because that is very true.
Yeah.
Well, the other issue I think you currently see all the time from my teaching experiences is in the classroom, you can go through talking about the theory, the practical application, and then you ask the patients, all right, I want you to go through this. But in their head, they're like, oh, well, we've already talked about this, Alec. We don't need to actually articulate it as if we're in a hypothetical patient situation. But in the clinical setting, you're forced into that situation. And I think for them, they actually get to go through that lived experience, that story. And it's actually something John and I have been talking a lot about recently, and even thinking about like how we structure the podcast, because it's one thing to talk about from a theoretical perspective, the healing process of tendons and the response to mechanical loading. It's a whole nother thing to actually have a go at applying that and like, well, that worked, or, well, that didn't work. Yeah. That's often when you learn the most, because in your head, you can have the most perfect, well thought out theory of this is how I'm going to manage this problem and it's going to work out great. But then the actual thing of going through and applying that, and not to mention actually talking to the person, and then you start to realise, oh shit, that didn't work, or geez, I really didn't know what I was talking about.
What I think is interesting too is when you actually talk in that realm, or even the patient asks a question that does dive a bit deeper, or even if it's in relation to like what you're doing and what your hypothesis is that you're working off, they actually get the patient themselves gets a much better appreciation of how much thinking goes into what you're doing. And I always notice that even with some of the students, as you talk them through things, it's beneficial both for you and for them. They recognise, oh wait, actually it's not just, as you said, you just pushing on a joint trying to mobilise it. You're actually, I'm feeling for this and I'm trying to see this response and I want to see what they say, and I'm trying to, and the student recognises really quickly like, oh okay, there's a lot of things going on here. And the patient actually starts to have that same sort of light bulb moment when they go, okay, my clinician's not an idiot. Like, I know that they're not saying anything about what's going on, but they're actually really thinking here.
I think that works even more so when things don't work out as planned.
Yeah.
Because if you're articulating to the patient what you're doing, and then it doesn't work, and like, actually, look, this is obviously not ideal in terms of I was expecting this outcome in this session. However, this actually gives me information straight away about like what is actually driving this pain, where is it coming from, what stimulus. So we clearly have some information straight away. This is not a key modulator to your problem. And I think actually that's a really valuable thing, because a lot of the time patients were like, okay, well, what's next? And you go, well, actually, this is what we need to do. And you're more likely to actually get them to follow on with that process, because the reality is things don't always work out in that kind of nice sequential fashion as you would like.
Yeah. And as an educator, what I've always struggled with personally is that and fought against the wanting to jump in and hurry things along. You know, we've only got 30 minutes with this client, get them out. And I always have to fight it, because I've always, with the student, I never give them an answer. I say, what did you feel? Or why do you think that happens? Or how are you going to treat that? And they go, I don't know, I'm going to do it. Why? Why are you saying that? Why are you going to work? You said mobilisation, why? And then sometimes what I get is, this is my silliness, the excitement I get is actually leading them down the garden path to go, yeah, that's why. You know, and a simple thing was, you know, the patient said, when I get sore, I like to wiggle it, but I don't just go, I have to hold it, almost stretch it. There's your mo. And the students go, and they're not thinking, it's academic, because it's not academic. Academic is they're taking the art of science. I think is probably the best way I can describe it.
I think what it teaches, and I think this is a useful thing, is I always say to a lot of the students, and even like our younger clinicians when they start, a lot of the times I don't think they actually look. They're looking in the direction, but they're not actually looking. And you say, okay, what did you see? And they go, oh, this. And you say, I didn't see that, so how did you see that?
They go through the motions, but they're actually not paying attention.
Because we don't challenge them to question.
Yeah, and that's what this process you're talking about does.
Why do they question them?
Yeah.
Why? And they don't, because I think that, you know, I don't know what the answer is here, because, you know, it's something that challenges me a bit, but we have got this CAM-med approach of competency-based learning and assessment. So we're looking at, can they do that? Can they observe a gait? And the students can do it, but they don't actually think about what they're seeing with gait.
And what does that mean? Just because they've seen this, what's that telling you? I see this a lot with coaching, because I get people when they'll come, and the really cool thing is now I get a lot of support through some of the VIS stuff, and we'll be doing something and they'll ask me, and sometimes I've thought about it and so I know, but sometimes it'll make me sort of question it. And then sometimes I'll actually ask, like I just turn it on them. I'm like, well, why do you think that I'm doing this? Or we saw that, but what do you think that that actually means? And an example of this is, I don't know, I feel like we may have even spoken about this in our last podcast, but maybe I'm getting confused. But
it needs a coffee.
So I started using, with the new VIS biomechanist, we started doing some testing using the IMU, devices in races, right? Because he doesn't have a lot of data on sprinters. And I said to him, I'd actually, like we're doing some in training, but I actually want more race data than I want training data. So we started using it, and he was like a kid in a can. He's like, oh, I sent you this one, and they did this, and they were really different, and this person had much more like lateral translation, and this one was much more vertical, and blah, blah, blah. And it was quite interesting. And they take so much data in it, it's a lot of like sifting through. I think he sent me a thing of a race, and it was 21,000 data points on his graph that he had to. I was wondering, I tried to open this Excel file, and I'm like, this is fucking taking forever to load. Like, what is going on? It's just a graph. And then I look through the actual raw data, and it's 21,000 cells. I'm like, oh, shit. So he's got this stuff, and he asked me a question. He said, one of my athletes, he says, they get a lot of lateral translation in their acceleration. So they're actually stepping a lot and like loading up onto then stacking their joints. Say if they go to the, like when they go on their left side, they're really going across to the left, and the right, they're really traveling across to the right. And he said to me, he goes, oh, well, you know, like that's bad. And I said, is it? Is it bad? And he goes, well, surely you want them going, you know, obvious thing is that they're running forward, you want them going forward. And I said, well, how is our tissue orientated? What direction are the fibers going? How do we create unique amounts of tension? And if we're going to do that across multiple chains, like, is that always going to go in the sagittal plane, or is it going to go in, you know, the transverse and frontal planes? And is it always negative if that happens, or is it not? And he's looking at me, he's going, oh, fuck, okay. He goes, what do you think? I said, I'm not sure yet, actually. I said, what I need to do, and this is why I'm collecting some of this data, is this athlete's at the moment running at this level. I want to see it either get worse or better in terms of their performance, and I want to see what that data says compared to this data, because actually we might find that more, you know, lateral translation is actually beneficial for this athlete. Yeah. So maybe from a cueing standpoint, we need to think about them really wanting to shift their weight onto that side, not limiting that. And I asked him the question, I said, you know, have you ever looked at the Chinese weightlifters and what they do from the bottom of their squat when they try and stand up, say, a snatch or a clean? I said, often their knees will come together, right? And if you ask someone who's overly simplistic with their understanding of it, they'll go, oh, they're weak in their, you know, their glutes, and so they need to work on that. And you go, okay, so that bloke there who can squat 300 kilos to the ground is weak in his glutes.
That's right.
Have a think about that statement that you're making. Right, like that doesn't pass the basic sniff test. So the reason they're doing it is they're uniquely trying to create tension by stretching their actual gluteal muscles and that lateral band that, you know, comes through the ITB and that lateral chain of connective tissue to actually get more tension so that they can get themselves out of the bottom of a squat where they have 200 kilos, right? They're actually doing that on purpose. Now, I don't know that they cue to do that, but they know not to limit it, for instance. So I said to him, I was like, if that's the case, maybe these athletes are working out a problem and a solution to a problem to create more force application. So I'm definitely not going to change it if I don't understand it well enough. So I was like, let's just keep collecting data over this next period, weeks, months, whatever, and work out whether that's a good thing for this athlete or a bad thing, because at the moment I can't say.
Yeah. Or don't just assume based on your model that the aesthetics of it is more important than the actual performance.
Well, I even said to him, I was like, have you seen a front-on shot of Usain Bolt sprinting out of the blocks? Yeah. And he goes, yeah. I said, what happens with his hip and his knee? He goes, oh, he gets a lot of hip adduction. His knee like really tracks in. I said, given that he's the fastest bloke ever through 60, do you think that he doesn't know how to accelerate properly? He goes, yeah, it probably does.
And that's that thing, you know, challenging your thought processes.
It makes me actually think of some of Carlos Decco's anatomy dissections, where if you look at the deep fascia of the leg, it actually goes in a spiral. It doesn't go in like purely longitudinal in a sagittal plane. It actually wraps around the leg.
Absolutely.
Which straight away makes you think like, well, okay, why is that? Why are we actually going to
the thing I will say, so he doesn't feel bad, to the biomechanist credit, he was like, actually, this is a really interesting way, and we've got to look at this more. He wasn't dismissive, and he wasn't uncomfortable about it. He just said, oh, okay, let's actually continue to develop this.
I mean that more as a general comment, because like I think the great one is the squat of like, if your knees go in, that's bad, and your glutes must be shutting off.
Yeah. It's not that simple.
Yeah, and that's going back to that anatomy, you know, the spirals. I mean, the Achilles tendon rotates as well.
That's a good example as well,
so, you know, you can't but help think that evolutionary, we've made these big springs, these big coils that can rotate and put tension and then come off again. I mean, that makes bipedalism so much less metabolically challenging.
Some pronation is necessary.
I agree totally.
Yeah.
But, you know, while you would say it, giving that example, you know, I always think about, have we taken away that thought or challenge by having true reductionists in our theories and in our research?
Well, and actually just on this topic, the one thing that I always find being critical of is, say, EMG work. And there's clearly...
You hate EMG studies.
I hate how it's been applied clinically, that's for sure.
Yeah,
I think there's clearly some value in EMG showing that you do get changes in neural patterns, particularly with acute or even chronic pain. It's more of what do you actually do with that information? Because I think by default, the most reductionistic thing is, well, can we provide internal cues to, quote, turn on the muscle? I think what they're referring to is the excitation of muscle, which, again, you can start to question how much does that electrical signal actually translate into force production. But then, more importantly, well, is this actually a particular pattern that someone's developed to adapt to the fact that they have pain or pathology? And then, in an acute setting, is that actually potentially protective? But then even in a chronic setting is the key process to then address that, to think of, well, we just need to do particular cueing to see that change in EMG signal? Or if you start to actually address other more significant factors, i.e. getting them to just start utilising that region, starting to improve their flexibility, changing the mechanics, you see over time a positive adaptation that creates that normal EMG pattern again.
The challenge is, what is normal?
Well, this is
because to me, if you take a whole lot of people first thing in the morning, for example, when I was competing, my morning runs, I look like an old man shuffling. Right. But the afternoon,
you're flying.
So if you took my EMG pattern in the morning or in the afternoon, you get two different EMG patterns. And I always get a little bit worried. We discredit this brain. And I remember talking to a physiologist, and he said that brain can make hundreds of calculations before you've even thought about making those calculations. Yeah. And your body will change.
Well, to be honest, it's probably thousands. Like, when you think about motor units within a muscle, we're talking about thousands of motor units. It's not just a matter of they all turn on or they all turn off. Multiply that by the hundreds of muscles that we have in our body. We're talking about patterns that are essentially almost infinite in nature. Yeah. But it's actually...
And we're not set. If we were set, the brain wouldn't be so plastic.
It's interesting you say that. I for the most recent week, I did a presentation for the clinic on a paper looking at risk factors for developing chronic low back pain. So it was a group of participants. They developed acute pain, and they followed them over 6 months. And they took a series of measures looking at psychological measures, symptoms, and also neurobiological. And interestingly, one novel finding from that study was people who were more likely to develop pain or still have pain at 6 months had lower excitation in their sensory motor cortex, and they also had lower amounts of brain-derived neurotrophic factor, which is a neurotransmitter that's important for neurogenesis and developing new synapses. And it's interesting because that straight away goes, well, these people obviously have a reduction in their cognitive capacity, and that's potentially limiting their ability to develop alternate strategies to adapt to the fact that they have a presence of pain for a period of time, which actually fits in really well with some of the other research of looking at people who have reduced variability or complexity in movement also have a higher prevalence of pain long term. So that in itself starts to make you think of, well, what is normal? Because if we see that people who are more likely to not experience long-term pain have more complexity or variability, in addition to actually having more excitation and ability to more neuroplasticity, it goes to show you that perhaps the idea of being able to have more variability in movement is potentially a good thing for reducing pain or injury.
I absolutely agree with that. And we did a bit of work when we looked at a population group, which was the Triathlon Academy, when I was working with them, and we had a high incidence of stress fractures. And so we took all these people, we measured their biomechanics, we measured their EMG, we measured their bone morphology with MRIs, and we looked at dietary analysis and everything else and training loads. And the one predictor that predicted stress fractures in this population group was whether they played a multi-directional sport prior to coming in, or were still doing, like hockey, netball, soccer, football. Those people didn't have stress fractures. All the ones that played unilateral, straight up and down sports had stress fractures. Yeah. And I think that's right. It's that neural plasticity. And I've always, with my clients, get them, when they running rehab, getting them back, I always say, I want you to run on the golf course. And they say, yeah, but it's not even. I said, yeah, I know.
That's the point.
Yeah, or go out and run on the trails. I want you to be able to go down, up, twist, change direction. And but I might get sore knees. Your body's not going to get better if you don't. And I think that's where, when you're looking at things, we've I wonder if this is another reason why we leave the profession, is that we get these normals that we are linear and we're doing all these things, and we then put in interventions like we see people internally rotating and the glutes turn off, so we put them on a glute training program and they still internally rotate, and you think, well,
what was the point of that?
What's the point? But you're not going through that process of saying, hang on, have they always done this? Or anatomically, what's going on with this? And I think that probably feeds into that when we assess students going through universities, there's only a right or wrong answer, and that makes it easier for us to mark. We don't go into that high-level thinking and getting them to debate and write a philosophical debate against us.
Well, that reminds me, sorry to interrupt you.
No,
do you remember you spoke about David Snowden? Do you know who David Snowden is?
Yeah.
And he was saying when he went to school, they used to have weekly discussions and weekly debates. And you had to actually participate in that. And I think...
Well, and the topic, they didn't know what the topic was, and they didn't know whether they'd have
position.
to be on the affirmative or...
and I feel like maybe that's something you can add in.
So what we're doing with...
Are you doing something like that?
Yeah, so that's one of the plans, is to have that. And so we're going to call it, bring back the grand rounds. And we're going to actually get the students, and this is my dream, whether it's going to happen, but my dream is that I'll have in a room, I'll have physio students, I'll have dietitian students, I'll have OTs, I have pods all sitting in the room, and we'll then create this patient. And the physios are going to be challenging the OTs. Why are you saying this? What's that? And the OTs are going to challenge the physios. So they're actually going to be looking at this avatar of a patient through a 360-degree lens, and so really challenge their thought processes. And also, that's within a multidisciplinary clinic, but then when we go to our smaller disciplinary type focus, where we huddle in our own little groups and thou shalt not take my patient away from me, that's what we'll be doing, on a weekly basis. We'll challenge people.
Well, I think the interesting part is that what you said, where you actually don't get to pick what side of the argument you're on.
Absolutely not.
Because I think that's more of an interest. It's more about that mental flexibility to be able to look at a problem and understand. And it's almost, like...
Well, you should be someone who, and this is something I wanted to ask you about when you think about how research and also researchers play a role in the current narrative of how physiotherapy, probably pedagogy in general in health sciences, but... if you're a researcher who works in a particular area, tendons, low back pain, whatever it is how well can you argue against your own point? If you know someone who is against your research and often talks out about it, can you actually go through in a really constructive way of understand where their points come from and be able to almost stillman the case?
Yeah, we've spoken about this, in the sense of it's... philosophy of science, and this is Karl Popper's whole argument, is falsification. It's you can't prove something, but you can probably get pretty close to proving it doesn't work, and it's a lot easier to prove something's wrong than something is right. And I don't know that a lot of people who we come off the clinical sciences, but they actually get taught to all right, as you said, disprove yourself.
Yeah, totally.
And do that often.
If this person that goes and speaks against you is here now, what would they say? And why would they refute?
It's such an
beliefs?
interesting process though. I remember, this will sound funny, but even at a personal level, I mentioned this to one of my athletes who's going through this period of life where you're kind of working out who you are. And I said, I remember being your age and actually asking myself the question constantly, because it made me push myself, was actually, John, are you full of shit?
You still don't ask yourself that now.
Well, I do. But now at least I know that some of my behaviours I feel justify the positions that I've taken.
Yeah.
Right. But there was
then you get to my age and you're full of shit, so you don't give up.
But the reason that I would ask myself that question is you say a lot of things when you're younger, and you do have conviction about what you're saying, but you actually don't necessarily have the evidence to prove that what you're saying is correct. And you've got to back it up with your behaviours over a period of time and then get the result and then be able to evaluate that. And I said to him, I was it's a really weird time in your life when, you're in, as I said, we mentioned it earlier, I was in my late 20s and I was I think I'm just full of shit. I say a lot of things and I think I can do lots of things, but I don't think I can do any of them. And then it was only with the repeated, turn up and keep doing it and keep trying things and keep exploring, and maybe I do it like this. And then eventually you kind of crack that nut a little bit and you go, oh, actually I'm not full of shit. Like the process that I said that I was going to go through, I actually went through with.
So there's a couple of points there that I think are really interesting. The first one is that we don't actually, you're quite right, we don't challenge the person that's going to challenge us and try and understand. And I think that's almost, having kids that have gone through the high school and now and university, they have this whole mentality about, and it really sort of highlighted to me when they were going through doing the debates, you're either right or wrong. There is the purpose of a debate, and it goes back to, if you read some of the early French philosophy, a debate is actually arriving at a position that is mutually respective but best for everyone. And we don't do that because our marking rubric says, in Jack's team, did he do this, did he do that, and did he do that? John's team this. We don't actually say, between the two of you, did we come up with a good spot? And I think that's where we've got to give people the freedom to change. We have this sort of, if I say
It's
that's
so
a
good
wooden
you
wall,
say that. It's so good you say that.
and I've got to be convicted to that for the rest of my life, then shoot me now, because I know that in 5 years' time I'll come back and go, actually, I don't think that's a wooden wall, because so-and-so told me, and you're going to start to think, we don't allow our students to, and I don't know how you do this, but it would be lovely to have a situation where a student can actually never fail, but they can be wrong.
Because the issue that you have is, as much as you would like to create a setting of, I want to see your clinical reasoning, I feel like often, again, in a university situation, it's like, no, that's wrong. It's like, even if you've actually shown really good reasoning and you've come to a conclusion of you're going to treat this way, which I might say disagree with in the sense of, well, that's not how I would do it. However, your actual process to coming to that answer is actually really good. So it doesn't actually necessarily matter, because you're going to learn the things that work
and you
or
might
don't
implement
work.
it. It might work, it might not.
Totally. It doesn't actually really matter so much. And because if you actually instill that skill, that person's going to learn over time. And not to mention at 5 years, they're actually going to be still learning. They're not going to be the person at 5 years who's going, you know what, I thought I was going to know everything once I finish uni, and I haven't, and I don't really feel like I know how to learn from
That's right. So there's two things there. And I think you're right. As a rubric, though, we mark them, and for consistency, we've got to look at every student paying this so that we can say across the board we're marking them level. That's the fault of that rubric, as far as I'm concerned. Or it's working the way we want to do it, if that's what your aim is. But we've instigated this in the last couple of years at the postgraduate level at Latrobe, where the rubric now marks the sequence and logicness of your argument, not whether you're right or wrong. And then we've put in the very end of the clinical reasoning form, what did you learn and how will this change your practice or thinking?
Yeah, that's good.
So that they're actually coming to the end and going, actually, and this has happened probably more often than I've actually expected, really. They've come to it and go, after doing this, I realised my thought process was wrong. I should have listened to the patient, because, they've got to the end of it going, hang on. And to me, I've won, if that's the case. Yeah. I think the other thing is, we also have, as a human, we don't like. There are very few of us that are quite happy to change. I mean, I'm very happy to say, have a thought process today, but I'm expecting it to change tomorrow. And I expect that to change because I'm going to learn something new from someone else that's going to make me, because that's some of the constructivism theories behind education, is we all bring to this stage all our past histories, all our family history, all our psychosocial stuff to the interpretation of this data. And that will change every time you change. And I remember.
Well, can I push on that? Jack and I spoke about this a couple of weeks ago, and we spoke a lot about values. And I think the interesting reason of whether someone changes or not, it depends very much on whether their values align with what the outcome is, or whether their values align with what their identity sort of suggests. Right, so we spoke about this a bit because I realised, and this was in a discussion. I think I mentioned I did that course, or I don't know if I mentioned I did that course on flow, and one of the mentors that I was having meetings with was asking me a bit about my process, and they give you all these recommendations to try and get into using more flow in your day to improve productivity. And I said, I've done this. And she goes, you've made some big changes. Like, how do you feel about that? I was like, I don't feel anything about that.
I think the issue here too, and a question I wanted to ask you about this is thinking about how research and researchers play into this, both at a university level, but I think even like at conferences. But the issue, I think, is you're rewarded for being more absolute in how you, in your statements of, okay, this is how I, as you know, if you're a researcher, this is what you need to do to treat patellar tendinopathy, whatever it is. The people who are a bit more open, who go like, oh, well, look, there's a lot of different variables we need to consider and you need to apply it to the individual and think of these things. They're like, no, just give me the answer. Like the people who give you the protocols are actually rewarded. Like, yes, I want it nice and clear on one A4 piece of paper. I can just remember that and I'll put it in the exam or I'll do that clinically. And so, yeah, I mean, I feel like I've probably expressed my opinion, but how do you think research and researchers potentially, maybe a better way to ask is, how do we actually overcome that problem? I think that's a problem that we see at the moment where clearly a lot of academics, a lot of lecturers at universities are researchers. They're typically full-time researchers. They obviously have great depth of knowledge in a particular area. We see that amplified. We see them usually put very high in the hierarchy. If you think about conferences, we don't see the clinicians presenting case studies or treating people. You see researchers presenting their work, and it's again very theoretical based. It's very much here's the most recent RC team.
You know how I reckon, like this is, I think back to what I was saying, I think that this is like, it comes down to whether that researcher or clinician is more interested in getting closer to the right answer or the right result, and that's what they value, versus whether they value being the person who's known as the expert or the right person. And we've all seen those people who love that. They value being the person, and then you can't change their mind. I'm right. Until they do research that changes their mind, they're not willing to do it because then they can't refer back to their own paper. Whereas the people that I find really interesting, we've had some of them on the podcast, of like, they'll actually go, oh, that's interesting. Maybe that is a closer sort of representation of what's going on. So the point I was making before with the value thing is like, she asked me, what you changed. I said, yeah, because my value is in getting a result and being successful in getting that result than it is what holding on to something says about me. And so that's that. You mentioned change, and I think identifying that in yourself or identifying that in that person of like, they will change depending on what they value. And if they value, getting the right answer for the right reason, like the right patient, they want to get a good patient outcome, they don't care if they're wrong. Because it's like, I'm committed to getting a good outcome for that patient. Yeah. Whereas if they value them being the expert or them being seen as the smart person in the room, then you're screwed, because I'm not changing my position on that.
Yeah. I think that's absolutely, and I see that being an internal driver.
Yeah.
But my question that I've always struggled with is, going back to your question, does the consumer drive that, or have they driven the consumer?
Yep.
So I don't know which one. I mean, I would say that they've probably driven the consumer by giving you the A4 page and you go home and treat the patient.
Well, this is true.
And then we've all seen this. You go off and you do a Mulligan's course, you come back and you do a MWM with every client and you get 60% success and you throw it away because it doesn't work. So I think there's that. I also think that, going to your point about researchers, I think there is a fault within research, and it's probably deeper than them just presenting or becoming narrow in their thing. Because I think that what happens is, to get the big NHMRC research funds, to get the big funding grants, you've got to have a proven track record. So therefore, all you're going to do is research in my area of osteoarthritis and knee, and I'm going to keep that. I'm not going to move very far because I want to build a track record. And then I'm going to get this big research grant, and I can't move off that. And so what happens, you are then going to be fulfilling your own self, and to be able to get a track record, I've got to do podcasts and deliver stuff to consumers. So I've got consumers are using my stuff. I can prove that, and so we suddenly get these people, they've stepped away from what the doctorate of philosophy really was, which is that whole thing about being philosophical. And, you know, if I could have my time, I'd love to go back to where you actually used to every Friday sit down and read with your professor, which essentially goes back to what we were talking about before, sitting down there and you don't know what topic we're going to talk about. We might talk about, you know, religion and philosophy, but I'm studying orthopedics, you know. So I think that's a big issue. And then what we do is they then step into a teaching. Well, that's the area they're good at, so they'll teach that, and therefore don't dare challenge me or the consumer doesn't challenge them. Does that make sense?
Yeah.
So I think that, and this is what excites me a little bit about it, in the sense that the universities are now starting to look at educators and teachers as well as researchers. So you've got these people that are going to be celebrated and getting promotion on being able to be a good educator and a teacher and go in the study of, you know, teaching and learning and teaching, as much as people on the other side getting the big research grants. You know, there are faults on both sides, but I think that if we could actually break down that idea of this NHMRC reliance on a single source of funding, you know, I don't know how you do that. All I can do is say that, you know, when I started my PhD, the universities were, this is in New Zealand, the university was given funding, and you could actually have a professor looking at some obscure thing, but he was getting paid, or she was getting paid. Didn't have to fight for money, didn't have to fight
it's such a challenge, isn't it?
Well, it seems to be big in the States, like that tenure, you know, which doesn't seem to be a thing in Australia, where you don't, after a certain period of time, it's like, cool, you've got a job, just you can do what you want basically now.
Yeah, absolutely.
Which is, I mean, a great opportunity for those who are genuinely creative and inquisitive, because then you can really open up into all sorts of areas or things that you've thought about for a long time, but now you go, okay, I don't have the constraints.
And in a way, we should be flipping it around and saying we should be paying for people that have hunches or ideas that are, well,
to explore things. Yeah.
And to me, that's where a lot more wild and wacky collaboration occurs, because with these small things we collaborate with people that we know and we keep the small team going, whereas, you know, I always tell a story about when satellite navigation was invented. It was actually someone that was sitting down doing satellite maps of the world, and they were talking over a cup of coffee with this other person who was actually trying to plot missiles and paths of missiles, and they said, well, why don't we get together? And satellite navigation was invented. And I think if you could go to the NH or national funding and say, I've got this idea, you know, I've got an anatomist here, and I've got a kinesiologist, and I've got a doctorate of philosophy and art history, and we're going to come up with this idea. And I say, there's 30 or 40,000, go and do it.
They won't. That's the question. Like, do you think that ever changes? Because there's clearly evidence that most innovation occurs with those kind of collaborative and sometimes those external industries kind of coming together. Do you think that we'll ever get smart enough to realise that from a funding point of view?
No, because I think that, you know, the neoliberalism will come out and say you've got to have an outcome from it. And so that's what I think is happening. You know, they'll say, if I'm putting in $60,000, we're giving you $100 million, we want $1 million worth of outcome from that.
I think also too, it's like this idea of novelty is also requires how open you are to change. And you know, as I've told you before, Richard, I'm doing this training program in Italy, and Antonio Stecco, who's in charge of the school, who is a researcher. He's an associate professor through New York University. So he does a lot of research into what he talks about and what they do clinically, both applied science and also basic science. And he was telling me a story where he was at a conference presenting some of his work, research work, and he goes, look, it's all well and good talking about what this thing fascial manipulation is and what do you need to do, but it's another thing to actually see it in practice. He goes, he has a significant long-term problem that you've had physios, chiros, sports docs, whoever look at, but haven't any solutions. Let's see if I can help you. And this guy comes like, yeah, I can help you out. He was in Amsterdam, I think, or he was in Holland. And this guy came, he said he came down, he'd had long-term shoulder pain, some like thoracic outlet syndrome symptoms, really limited range of movement. So Antonio does his assessment, does his treatment, and it's very manual therapy based, And like pre and post is like, oh my God, this range of movement, I haven't had this for years. And someone in the audience goes, how dare you? How dare you? How much did he pay you to do this? And the guy's like, what are you talking about? He goes, he's obviously paid you just to act this. And he goes, I've never met this guy before in my life. It's just like, I'm completely offended that you think that you could just come and, manipulate us like this. And he said they almost came to blows. It was just like he thought, because for him, obviously, it was just like, I've never seen something like this before. And sometimes, like something like that, if it's quite a significant effect in a very short period of time, you're like, what the hell's going on here? But clearly it was like that guy was just not having a bar of the fact of, I'm not even open to the idea that this could be something that I haven't thought about or might have really big clinical significance. And so, because it was all well and good when he was talking about his research and being, like, here are our results and this is what we've found. That was all fine. But when he actually applied it to, like, this is what potential effect it has, no not having it.
No.
That's quite funny.
And, I keep thinking about my experience, and I remember meeting a guy by the name of Albert Chung, and he was a surveyor. So he used to do three-dimensional topographical maps, so flying over or going under the water and mapping the contours.
It's quite interesting.
And we ended up having a chat, and I said, you know what? We ended up talking about how you could probably use that for facial recognition and surgery. And so we did a whole lot of work looking at doing topographical with stereophotogrammetry of people's faces, and that ended up then doing, with videos, we were looking at the deformation of a foot through a glass force plate, so we could actually have topographical maps of people's feet and looking at pressures and things. To me, that's what
excites
people. And he went on and did a whole career on it, and we sort of moved universities, so we never carried on. But that's the sort of stuff that I think that needs to sort of happen within a university, because you've got all these wonderful educated people, and I think that the other thing that I think that happens with academia and is that we've got these extremely bright people, and often the people that are really that do really well in research are very disciplined, very almost on the spectrum, if I dare say that. Yeah, they are. They're that type of person, and
you kind of need to have those characteristics to be really focused on
100%,
one problem.
100%, and I wouldn't discredit them in any way. And they're really successful, but I've always said this, you can't then make them into a teacher, because the teacher has to then be a little bit more philosophical. And I go back to your thing that, they feel comfort by actually confirmation, whereas the other person, and I think these are probably a good clinician, is actually, poke someone, got a diagnosis wrong, and the one that are happy to say, I don't know why, but let's go and hunt out a little bit more and find out why, are probably the teacher we need to have. We need to have both. I think we can't have one without
It's
the
interesting. I'm trying to tie things together here, so if this makes no sense, you guys can tell me I'm off track. But I recently listened to Rick Rubin's book about the creative process, Rick Rubin being the music producer. And it's a very philosophical book, actually. It's very zen. And one of the things that he talks about, which I feel like is a little bit related to what you're saying, is that creativity that happens for that researcher, that person who's curious, who's a little bit of a maverick looking at stuff, and maybe is a bit odd in general, seems to be similar to an artist in the sense that they're creating something that maybe, for us it's knowledge, but for them it's like an artistic sort of expression. And one of the things that he said, which I think is really interesting, is once you put that information out into the world, it's no longer yours, and it's no longer your position to influence how people interpret that, which I found really interesting. And he also said that good art is usually made by people who are not trying to create a certain response from the people consuming it. He said if you do that, it becomes very artificial. And I feel like one of the things that we have with crap research is they're actually looking for a specific answer. So you see a lot of bullshit of playing with data, but also they're not doing it for the reason you said of like, I'm actually just exploring this and I want to see where this goes. And it made me, as you were saying that, it made me think maybe one of the problems, as you said, is there's people who should be interpreting it are those educators, are the people who are going to pass that on, not the person who's created it. It's not necessarily their job to tell people how to use that information, even though they're the one who's created it. I don't know if that has any crossover.
Yeah, look, it does. And I think, I remember reading a book, and I cannot remember why you were saying that, but they were basically saying the same thing. When you look at a piece of artwork, because you bring your own social stuff, your own knowledge, you'll look at that art, Jack and I'll look at that,
See, different.
Go, that's crap, or, wow, I really like that. And you look at them and go, what's going on with that? But for some reason, there was another, what's his name? He was a Dutch philosopher. He basically said, we've created a society where we're actually rewarded for for being uniformed. We don't actually allow the mavericks. We don't allow those weird and off the beat. We lock them away and say they're mad, or dismiss them and say they're crazy. But as a society, we don't. We almost like. And I always say, like, the latest uniform is those extended eyelashes and fake tans. Where everyone wears them because they want to conform, because we don't like someone that's not in that space. So is that human nature, or are we actually, as a society, driving this confirmation of uniformity? Everyone that comes in with low back pain has this, and we need to do this. Not. Everyone's different, guys.
Yeah, and treat them as such.
Yeah. And we give lip service to this biopsychosocial model, but I'm bringing stuff, you're bringing stuff. Why? And how does that work?
Well, I think what you're highlighting there too is the biopsychosocial model doesn't just mean that there's psychological social factors. It means that there's actually quite a varying amount of outcomes that are happening.
Yeah, an interplay.
But I think you're absolutely right. But it's not at that point. So this is very Western medicine, isn't it? That if I go and hit my toe with a hammer, then I'm going to get a hematoma and I'm going to get pain. Whereas if you look at Eastern philosophy, is why was that hammer in the room?
That's an interesting question.
And you go, because that's what they do. They say
I'm interested to see how you apply this to the physiotherapy curriculum. Actually,
I don't have to do that anymore. But it is interesting, and that we think of the biopsychosocial model as that, instead of thinking of it that the person's bringing this to the table, and this is something that was brought out when coming from New Zealand. We're very. I would have to say it, we're more advanced than the Australians as far as the cultural awareness and cultural sensitivity, because we've grown up with the treaty, and we've grown and so you think about a lot. When the Māoris come to you as a health practitioner, we don't make the assumption they're dumb because we're looking at it from my point of view of Western privileged. We're actually saying, why do you say that? And then someone said, well, that's motivational interviewing. I said, no, it's not. It's just being inquisitive. And knowing that they're going to bring this whole unique biology, unique psychology, and unique social...
John and I have talked about this a fair bit recently, of like understanding that beliefs, perceptions, psychology influence physiology. Like, it's not just a simple thing of like, well, he believes that, but I'm just going to brush that to one side because it's not really relevant. It's like, no, actually, it's very relevant. That's actually influencing what's happening at a cellular level even.
Yeah, and that just happens, and we all know as athletes and actually as coaches, the person can be physically exhausted and running as fast as they can, but they can still do that spurt at the last minute to cross the line first. Now that's the top 2 inches driving something there, and belief that they can do it. And I think that drives that physiology to say, I need a bit more blood pressure, I need a little bit more of that. But I always find that interesting, and I find that fascinating when I'm educating students. One of the first questions I ask is, so why do you say that? What brings you to do that? And I always say to the students too, that I say to them, okay, and I always ask them, how do you do a jigsaw puzzle? And then I explain to them, that's exactly how you treat a patient. some people do the corners and the edges because they know, and I asked them, why do they do that? And they said, I can recognise the two edges, the sharp edges, and I can put them together. And I said, well, so what makes you think what order? And they said, colours and patterns. Some students take it and go, well, I know this is a puzzle of a hot air balloon, and I know there's red, green and blue, so I'm going to put the hot air balloon and I'll make that first, and they'll work out. Now, I'm not right, they're not wrong in how they do the puzzle, but it's actually getting them to think about why they do that, and can they actually adapt something from the person that does it from the edges. And I think that's the fascination.
Yeah.
From your experience teaching, what influence do you find someone's age and also someone's background, like particularly if you've got international students, has on how they approach being able to solve a problem?
I don't know whether it's age. There's a certain element of as they get older, they're more receptible. They adopt the ability of being wrong a little earlier than someone that's younger. Everyone still gets to that phase. Well, I try and get them to that phase. Cultural background. I think if you come from a cultural background, it's pretty easy, and I've seen this with other supervisors, dismiss them. Why they do something is because they've bought this approach or this philosophy or this view of what health is. And if you look at the Polynesian, Micronesian view of health is different to what Western persons are, yet we base our whole health model on the Western model of health. Now, it's not wrong. It's just that we don't understand that to be able to adapt our view. I think the key, probably the biggest influence is whether people come from, no, it hasn't come from, whether people have had to work to where they are or arrived at where they are. And I think that we can have a cookie cutter style of person that comes out because we assess. We'll go back to the thing about having a rubric that says yes or no, and the answer that we're saying is yes or no on the rubrics is because us white middle class people have sat down and said this is what it should be, instead of going around and saying, argue your point. But I think the people that have had to work to and work hard to get to are the people that are more receptive to being able to understand an open-mindedness than the people that have come to and say, well, I can rote learn that. I remember A plus B equals C, and I write the C down, they get that tick, you move on to the next square. The people that have thought, get C wrong, had to go back and work it out, and then come back and get C, other people that are the other people that I think change the best and change the most.
All right. I think we've covered a fair bit there. Nearly an hour and 20 minutes in, Joe.
Well, I mean, a question we've been asking all of our guests is, to finish off with, is outside of your work, or it may be even related to your work, is there anything that you're learning about or interested in exploring that you're doing in your personal or professional life, outside of what we just talked about?
Right now, I'm doing a lot of reading and investigation around Russian philosophy and the whole.
How does Russian philosophy differ?
It doesn't really. It's interesting if you read the philosophy or the practice of philosophy. It's not really that different. But what I'm finding interesting is that the communism that was around has influenced their thought processes. And
do you see that through distinct time periods?
Yes,
that, all of a
from
sudden
the Tsar, and then you go into the
communist period.
Yeah, very much. And I don't think it's what I'm finding fascinating, and the reason I've got into there, because I was fascinated in the Ukraine war and why Russia was constantly trying to invade Ukraine, and I thought there must be something there because I think Stalin invaded them many years ago and had the same thing about, we're wiping them out, they're a sleeping nation, and the same thing we had with our Aboriginal and Torres Strait Islanders here in Australia. But I was more interested in how do people who are the philosophers of life and the famous philosophers express their thought process, and does that influence, or is that influenced by the era? And so,
Of course, yeah, it has to be, doesn't it?
yeah, well, it does.
Because you, as you said before, you are a product of all of those influences.
So I ended up reading about Putin, and then I ended up reading about this. So I don't know where I'll end up reading.
That's very good.
Oh, thank you, Richard.
Yeah, thank you so much, mate.
Thanks for having me. It's great.